Thank you. Well, it's my great honor to introduce David Friedman as the 2025 American Glaucoma Society Subspecialty Day Lecturer. David was an undergraduate at Yale University, and he attended Harvard Medical School. He then went on to pursue residency training at Wills Eye Hospital, and he was actually a resident a year behind me. And back in the day at Wills, the class immediately ahead of you was responsible for, teaching you the ropes. So some might suggest that I taught David Friedman everything he knows about ophthalmology. But the truth is actually the opposite. And I learned a lot more from David than he learned from me during residency and well beyond. And I think everybody in the room has been a beneficiary of his excellent teaching. David went on to pursue fellowship training at Johns Hopkins University, and he remained at the Wilmer Eye Institute for much of his illustrious career. He went on to obtain MPH and PhD degrees during his time at Johns Hopkins. In 2019, David returned to Harvard Medical School to serve as the director of the Glaucoma Service and medical director for clinical research for the Massachusetts Eye and Ear. He is the Elizabeth Ives Kogan Professor at the Harvard Medical School, and he maintained an adjunct professor appointment of international health at Johns Hopkins Bloomberg School of Public Health. David has made incredible contributions to the medical literature with 469 peer-reviewed publications, 9 book chapters, 1 book. He's delivered 17 named lectures, and he's a member of several professional societies, including the Glaucoma Research Society and Academia Ophthalmologica Internationalis. And these are both very exclusive and prestigious societies that restrict their membership to only 100 active members. David's career has really been defined by a remarkable commitment to service, and there are really few individuals that have contributed more profoundly to the world of ophthalmology. His contributions are really far too numerous to mention in their entirety, but I'll highlight a few. He previously chaired this very program, that's the Glaucoma Subspecialty Day program. He served on several AGS committees, including chair of the Practice Guidelines Subcommittee and the Program Committee. And in Orbis International, he is vice chair of the board of the directors, chair of the Program Committee, and a member of the Board of Governors. David has had many other leadership positions in the World Glaucoma Association, as well in the Glaucoma Research Foundation and Singapore National Eye Center. Here are a partial list of awards that David has received, including being named on the Ophthalmologist Power List of the 100 most influential ophthalmologists globally for multiple years. Shown here is what I call the Brain Trust in angle closure glaucoma, and it includes Tin Ong, He, Ming Guang, David, and Paul Foster. And these were leaders in the landmark ZAP trial, and they collaborated on several other projects relating to angle closure glaucoma. And they say, behind every great man is a greater woman and a supportive family. And pictured here is David's wife, Rocio, their younger daughter, Amalia, older daughter, Irene, son, Isaac, and dog, Toasty. And these beautiful photos show another dimension to David's really remarkable life and remind us of what he really considers most important. So please join me in welcoming David to the podium as the 2025 AGS Subspecialty Day Lecturer.
Today I'm going to try to help everyone think through what we're doing, what we've been doing, and what we ought to be doing for our patients. I have financial disclosures, but none of them are relevant to what I'm going to talk about today. I want to first say and acknowledge that a career in medicine requires a tremendous amount of training, mentorship, and advising, and I have relied very heavily on colleagues for all the work I've done, not only for their help in thinking through how to think about the disease we study and work on, but also their friendship, their support. Really, this is just a portion of the main people that I've come to depend very heavily on for all of those things. Medicine's constantly evolving, and I think back to early in my career trying to find a field in a chart loaded with fields interspersed pages apart and compare them. And that makes me think of Mesmer trying to treat eye disease with magnetism. You know, it was kind of that kind of era, and I think we're moving away from that to an era where we really can offer unbelievably personalized and well thought out care for each of our patients. I worry that we are not providing ideal glaucoma management. If you think about what we should be doing, every affected individual would be under care. The care we provided would prevent the disease from getting worse, and the patient's needs and well-being would be addressed. But unfortunately, when we think about the real world, it's a leaky pipe, and this is taken from Hugh Taylor. And what we have is a huge glaucoma population, and as we go down, some people get diagnosed, some get treated, some remain in care and are sustained, and then ultimately this very small few drops at the bottom have their vision preserved. 90% of glaucoma is undiagnosed in developing countries, and about 50%, at least in the United States. Sorry, my clicking's a little off. And I feel that in the past, we have failed at population-based screening. I was fortunate to receive funding from the Centers for Disease Control to do a large screening program in East Baltimore. We screened over 9,000 individuals at health fairs and other settings. And we identified a lot of people who needed referral, but in the end, only about half of those would show up for the exam after they were told they needed it, despite tremendous efforts of free evaluation and offering free glasses. So how do we ensure that all of those with glaucoma are receiving care? You have to look at populations that are enriched for disease when you do screening. And one easy way that we all can do in our offices is encourage family members, particularly siblings and children, to be evaluated. First-degree relatives have about an 8-fold risk of glaucoma. But we can also, in the future, where we're going, start using polygenic risk scores. We have data unpublished from comparing people who are in the top decile of glaucoma risk to the bottom decile, and those in the top decile had nearly 20% prevalence of glaucoma. And in the future, and even today, we should be screening in a range of settings. This is a device from a company that can take your picture, self-directed, provide an output on whether you have glaucoma, macular degeneration, diabetic retinopathy, and others. And this is available today. It's being made. It's not FDA approved, this particular one. But we are in a world where this could happen at Target, at McDonald's, at your local DMV. Let's face it, AI is here, it's here to stay, it's diffusing through healthcare, and it's going to be part of how we identify patients moving ahead. And there's already good early data showing that even with these relatively early AI models in 2017, we could identify people with glaucoma just from a single fundus photograph. We have a presentation coming on Sunday about a CDC-funded screening trial that we're doing using AI, so I'm just highlighting that here. What I want us to do once we identify all these patients is to provide personalized care to them. And I think we all do to some degree. We think we do. We try to. We always consider the baseline pressure when we set a target, at least I hope we do. We avoid beta blockers in patients with asthma. And we treat angle closure differently from open-angle glaucoma because we have good clinical trial data to support this. But on average, when I think about what I do with most of my patients, what we all do is we see them in a similar time frame. We have similar treatment algorithms for regardless of what the open-angle glaucoma condition is based upon. And we're going to have major advances in glaucoma genetics. We already do, are going to help us to do a better job here. So let's think about this kind of one-size-fits-all approach. We have, let's say, 3 different patients, 1 green, 1 red, 1 blue, but we treat them all with the blue pill. And so the blue person does great, but the green person didn't really get any help, and the red person we may have harmed. And I think of, let's just say, a lower pressure glaucoma where we give them a lot of meds that probably aren't going to help them very much. But with precision medicine, we'll have these 3 different groups, and we'll also have them known in their groups, and we'll have individualized treatments for each of them. And that's the true promise of where we're moving, and there's some evidence for that already I'll discuss in a moment. This will rely very heavily on genetics. Genetics can allow us to personalize care in several ways. We have direct gene therapies in ophthalmology already, and these can replace abnormal genes. And knowing one's genes and knowing the risk can help us understand response to therapy, likelihood of vision loss, and so on. This is just the Luxturna pivotal trial where they gave a subretinal AAV injection, and there was a dramatic increase in vision with that single injection. Genetic factors can influence treatment response. This is a very early study from 2007 showing that complement factor H gene types affect the response to bevacizumab. If you had the CC genotype, you were very unlikely to respond, whereas with TT and TC genotypes, you responded quite well. And imagine if we all knew all our genomes and we knew what genotypes we were, not just our phenotypes, we might know that we respond differently to treatment A or treatment B. Another really important area where we should be doing better and can do better is in juvenile onset glaucomas. I want to thank Janie Wiggs for this. This is an example of a family that's diagnosed with a proband diagnosed at the age of 40 who needs surgery, and they have a mycilin mutation. And the child shown on the bottom who's mycilin positive has elevated pressure, and they're going to have therapy initiated. The other child that's mycilin positive needs surveillance. But what great news, these 2 individuals need nothing. They do not have a risk and do not have to live with a lifetime of worrying, do I have this problem? So testing them makes sense. And this is also a case where a directed treatment for these people can be curative, and that's been published with goniotomy from the group in Iowa in some of these early onset situations. So JOAG patients should all have their DNA analyzed to see if they carry a major variant and to help in prognosticating for family members. But we have even more ability to look at genetics across populations, and this just shows that we can come up with an estimate of risk based on the number of variants that an individual has related to glaucoma. And that's called a polygenic risk score, which is a measure of genome-wide genetic risk. It's based on the total number of risk alleles, and more alleles have more disease. It's more complicated than that, and there are formulas that take a long time to derive, but that's basically what it does. And in 2021, we had 127 POAG loci. By 2023, we have 308. I'm not saying this is an asymptotic thing that's just going to keep going, but we constantly are gaining more insight into the genes related to glaucoma and glaucoma phenotypes. And right now, we're pouring them all together, but there will be a future where we can look at groupings of genes as well to help us with risk assessment. And we know that these genes affect risk. If you're in the top decile of PRS, of the polygenic risk score, you have 15 times the risk of having glaucoma just walking around right now of somebody in the bottom decile. Who here would not want to know which decile he or she is in, right? We should know this, right? We could do this now. And as I said before, we did actually examine people looking at higher and lower PRS, And we found much higher rates in the higher PRS, and half of those people were undiagnosed. Imagine again a world where everybody has their PRS, and then all of those top 1 or 2 deciles get checked regularly. How much glaucoma blindness could we prevent if we found those people early? We know that people with higher PRS are more likely to be diagnosed at a younger age. They have thinner retinal nerve fiber layers, and they're more likely under care to need trabeculectomy. When you're sitting across from your patient, don't you want to know if they're in this high risk or low risk as you're thinking about that borderline field change? Genetic factors also likely will influence treatment to glaucoma. I mentioned the myocilin one, but there's also several genes related to mitochondrial function, and maybe people with those genetic abnormalities will respond better to things like nicotinamide, and we could focus on giving the drugs to them and not waste those drugs on others where it may be less effective. So the take-home messages from this part of my talk is that genetic information can be used now in patient care, and we have funding, Lou Pasquale and Jenny Wiggs are the PIs, to start trying to apply this in clinical settings. Massive changes are happening. The genetic revolution, which I've watched for my entire career, is finally here. We really can use this information. And I think it certainly will become a part of routine care, and we will be choosing therapies based on genetic risks. I'm going to shift gears, and I'll mention that I used ChatGPT for this, to create this shifting gears slide. I am going to focus now on how do we provide the best possible care to our patients. And many of the themes I'm going to cover here were covered by our panelists ahead of me, so they've laid the groundwork and made it easier for me to talk to you now. I want to emphasize that if you put the patient at the center of your thinking, you will be a better clinician. And it is a partnership with our patients where we, as doctors, are best. And we really need to understand them and provide them what they need in order to make sure the care we give is useful. One of the things I worry about is the emphasis on blindness in glaucoma. Disability is very common in our glaucoma patients. Pradeep Ramalu did this whole body of work looking at reading and other functions. And in glaucoma patients, if it's present, you read 32 words per minute less. That's a lot less. It's more than being educated 4 years less. That's how much slower one reads. And if you think about reading to yourself, the individuals slow down their reading speed after 10 minutes far more commonly than controls. Almost half of glaucoma patients slow down their reading speed, and that's why many of them give up reading. Mobility is greatly impacted. Glaucoma in both eyes leads to walking 2.5 meters less per minute, which means 10 minutes later, you're 25 meters ahead of your glaucoma friend. And they bump into things more, and they actually walk less overall, probably due to a combination of fear of falling, difficulty walking, and then also losing muscle mass because they're not walking. But do we know our patients' disabilities? Do we engage with patients around their disabilities? Very rarely, I'll have to say. Do we collect routinely patient-reported outcomes? This is a schematic of something that we did do research on. There are computer-assisted designs where you can ask patients very quickly and get to their limitations. In the top row, you see ocular symptoms, not bad for this patient. In the middle, seeing things, a little bit difficult. And then mobility, not so much, but then depression, anxiety, really bad. Wouldn't you like to have this scorecard on the patient that you're talking to in your clinic? It could totally change the conversation. You could talk to them about maybe seeing someone for help, or maybe occupational therapy could come to the house. We also tend to miss the boat, I think, on what is most important in the patient-doctor interaction. What are we trying to achieve for most patients is not to tell them about how glaucoma happens, how their fields are, how their pressure is. What we want them to do when they leave us is to take their drops, right? Because pressure lowering is the single thing that can avoid vision loss at present for glaucoma. And we've heard about this, but the LIGHT trial is seminal. I used to say you can choose medicines or laser, and now I say I recommend laser first. And the reason I do that is this is an instance where we know that treatment with laser first results in less visual field loss. Fast progressors were far more likely in the medicine group, and the overall mean deviation was less in the group treated with lasers. As was noted previously, 70% were on no drops, and IOP was at target at 6 years, and the time to surgery was far less, and progression was less likely. There's sort of a no-brainer here. We should be doing laser trabeculoplasty more as first-line therapy. Many patients don't take medicines as prescribed, and we had a whole talk about adherence. I'm going to briefly run through that again. This was a group of people that we gave a monitoring device to every time they clicked it. We measured it, and they knew they were being monitored. Okay, this is an ideal world, and you can see the distribution is imperfect for sure. This shows what happens when you follow patients over time and do nothing. And when we provided an intervention to help patients do better, we talked to them about drop taking, we set alarms, and we called them initially to remind them. They did much better, increasing adherence substantially. We repeated this in a study with an automated dose reminder, and I completely agree, if we can encourage our patients to set alarms on their phones, they will do much better with drops. We also need to be able to identify those patients who are poorly adherent. And we do not, as a group, communicate well with patients. We can communicate better. We had a study where we video and audio taped physicians caring for patients, and then we provided a course in how to communicate better and identify non-adherence, and we repeated that a couple of months later. And after the interventions, physicians asked twice as many questions. We often, as ophthalmologists, do not ask many questions. And we avoided the "you're taking your COSOPT, right?" question, and transformed that into, "How are you taking your medicines? Tell me about your medicines." And that increased dramatically just through thinking about how we speak to patients. And forming a non-judgmental environment will allow for honest back and forth with you and the patient. And this, in fact, led to substantial discussions around adherence and better detection of poor adherence, which is exactly what we want so we can help our patients to do better and to take their medications better. We also can improve how we care for our patients. If you think about our current management approach, it is really inefficient and often wastes a lot of time. This is a patient who really looks like they have preparametric glaucoma, inferior nerve is worrisome, pressure was elevated, we started treatment, and then we watched, and we saw them probably every 6 months until 6 years later, we found a reproducible field change. How much of that time was well used? I mean, I knew their grandkids really well. I knew all about the relative who came with them in the car, but did I need for all of that to happen in my office? And I would argue absolutely not. What we need to monitor patients is visual acuity, and you can do that off an iPad, an iPhone, any phone, and also a computer. So there's a million ways that that can be done reliably now. Eye pressure, testing of side vision, and imaging of the optic nerve. All of these can be done outside of the office. The eye care is available. There'll be others. There's no reason that would be the only one forever. There's ways that people could test themselves at home using tablets or virtual reality headsets. For things like OCT high capital devices that are hard to make inexpensive, we can have high throughput areas where people can go and get testing done. We can capture other data that way as well. Or we could set up stations where somebody just comes in, gets it all done, and we get all the information sent to us. And in fact, in the UK, they have this approach in London and other locations. We're testing the fields much too infrequently. And the reason I say that is this just shows some modeling of data where if you test a patient once a year, it will take you 5 years to detect rapid worsening of the visual field. This is a patient getting worse at a decibel a year, and you will take 5 years to know that they've gotten worse. In our large database review, looking at charts from one US health carrier, glaucoma patients were being followed on average by less than 1 field a year. So it could take 10 years to find this rapidly progressing individual. What about this comparison? These are 2 visual fields taken about 6 months apart. If you look at dense testing, so think about this, how often do you have 5 tests on a patient? Not everybody in your practice will have 5 tests, but these 5 tests were done in a study by Felipe Medeiros within a month. And then 6 months, the same 5 tests were repeated, not on the same day, on different days. And what you can see is there's clearly worsening in this patient, and then a couple years later, they are dramatically worse. And the slope was very rapid in this patient and highly statistically significant. So within 6 months, you can intervene on this person and help prevent dramatic worsening. And this was the case in 15% of the eyes in that study, with 18 of the 19 progressing by more than 1 decibel per year in the slope at 6 months. So we have to change how we're monitoring patients. We ought to be doing more frequent testing, including high-density home testing. I'm not recommending any of the devices right now because we need data to support the shift, but there are a lot of devices out there that could do this. It would put less burden on patients and their families and on our facilities. We just heard about Wisconsin with almost nobody there to see the patients. We could be doing a lot of this outside of the office. And we could increase access because people who live far from us struggle to come to us. So what is the future of care? What will we be doing as we move ahead? I think that patients will most likely be identified by photos or very high eye pressure. I think we should always check a pressure when we're checking a patient for glaucoma because there's going to be a small, real proportion who have high pressure where if you found it that day, you could prevent vision loss when the nerve is still healthy. And these will be done at high throughput areas. And then we'll do our full dance with the patient. We'll go through the whole process of figuring out where they are and staging and helping decide treatments. But there'll be far fewer in-person visits. Monitoring will take place away from us, either in lower cost, easier settings or at home. And then we'll see the patients when we really need to make a change in care, maybe by video, maybe in person. We're lacking appropriate cost structures for this kind of thing. We don't really have a way to integrate all these data. There are systems, but not easy to use across institution systems. So we're going to need to work that out. There are organizations and companies that have created, the one on the left was in Australia. It was an AI screening for eye disease of the retina with a photo. On the right is a company that provided all of the imaging for the eye and all the testing in one little sphere there. But we can do better as well at caring for people with glaucoma. And as I said, we can identify patients through proper and appropriate screening of enriched populations, and we have the tools for this. But we also have to ensure that once screened, patients enter our care process and receive the care they need. We also need to think and focus on the patient's needs. We should be identifying how our patients are affected by their illness, and we should refer appropriately to vision rehabilitation, occupational health, social services when we identify this. And we can improve the detection of progression by testing more densely, which will allow us to avoid preventable disability and blindness. and enable those who live far from us, who struggle to attend meetings, to be monitored locally. I am looking forward to this era. It's a big change. It's going to be upsetting in some ways and revolutionary in some ways, but more people who need care will receive it, and interventions will be focused on their individual genetic risk, personal needs, and disease state, and we'll have better information and improved tools to detect progression. And we, as doctors, will spend more time caring for patients who really need the interventions and really need our abilities. So I think we're moving into a new era of care, and I'm really looking forward to it. Thank you very much.
Well, David, thanks for another inspirational lecture. On behalf of the AGS, I want to provide you with this certificate of recognition. And also, we are mailing a Crystal Award to you in Boston. Again, let's have another round of applause for David.